needed and going whatever topic is needed. I like to research and discover things dealing with other organizations where I stay very active. And I want to thank y'all for allowing me to be here today.
Thank you so much, Ms. Dee, and we're so excited to have you be a part of this call today. So thank you so much for taking the time to be with us. We really appreciate it.
And thank you. Thank you.
People are still entering the webinar or the meeting. So if you want to continue to introduce yourself in the chat, please go ahead and do so. Maybe because we have kind of a full agenda and we want to give as much time as possible to Ms. Dee and the others who are joining us today. Why don't we go ahead and get started? Welcome back, everyone, to the second session of our Diabetes Continuum of Care, Developing Patient-Centered Resources for Diabetes Care. Next slide, please. So just a quick refresher about this Learning Collaborative. So this Learning Collaborative is focused on the diabetes continuum of care. It was organized by 14 national training and technical assistance partner organizations. We are organizations who receive funding through the Health Resources and Services Administration to provide training and technical assistance to health centers. And these are the 14 organizations who participate in this collaborative. And for this particular topic, we have 3 partners who have helped organize this particular series of webinars. And we are Farm Worker Justice, which is my organization, the National Nurse-Led Care Consortium, and National Healthcare for the Homeless Council. And today you'll be hearing from Darlene Jenkins, who's a Senior Director of Programs at the National Healthcare for the Homeless Council, and she will be leading today's session today. So before we jump into the meat of today's session, I just want to do a quick reminder about the SMART goals. So for those of you who were able to join us last week, we talked about how for this series, we would like you to think about an action plan. And so on the Google site that we created for all of you, there is a template of an action plan. And what we want you to start thinking about, especially with today's session and then next week's session, is to start thinking about what are the actions that I can take in my organization? How can I apply what I'm learning in these sessions and maybe improve or create a resource really focused on the patient-centered experience? And so what we hope that you will do is think about these SMART goals: specific, measurable, achievable, realistic, and timely. And think about that. We encourage you to start thinking about your action plan, start thinking about maybe one specific item that you'd like to take out of this and apply to your organization, or something that you would like to implement in your organization. So we encourage you to start thinking about that during today's session, and during our last session in a couple of weeks, we will really dive deep into the action plans and talk about what we've learned and how we can apply all of the great information that has been shared during this series as we kind of move forward in the rest of the year. So with that, I am going to turn it over to Darlene, who will introduce today's topic.
Great. Thank you so much, Alexis. And hello, everyone. So glad that you're able to join us today. This is session 2 for the Learning Collaborative. And today we're going to talk about some areas where we need to explore how do we really start getting deep, or really considering what needs to be in place to develop patient-centered resources. So we have some presenters that we're going to focus on our learning objective. We want to make sure that we understand the implicit bias, how it may be a barrier to developing patient resources, also understand how cultural humility may be a facilitator, and then identify strategies on how to engage patients or clients in developing patient-centered resources for diabetes care. Our presenters for today's session, first is Kate Gleason-Bachman. Kate is with the National Healthcare for the Homeless Council. She is a clinical and quality nurse manager here at the council. Our other presenter, and hopefully Art will make it. I don't see him on the participant list, but Art Rios is supposed to join us today as well. Art is the chair of the National Consumer Advisory Board, and Art is located in Portland, Oregon. I should have mentioned that Kate is located in Philadelphia, Pennsylvania. And then we have Dee Dee Blanchard, and you heard Dee Dee introduce herself earlier. And Dee Dee is also a member of the National Consumer Advisory Board, and she is located in Atlanta, Georgia. So with those introductions, I'm going to turn it over to Kate and have her talk a little bit to you about implicit bias. Kate?
Hi, everybody. Welcome. Thank you so much for joining us today. So I'm here just to kind of set the stage and some of the groundwork for what we're going to be talking about today and hearing the expertise and experience from Dee Dee and Art. So I'm going to talk about implicit bias, talk about cultural humility, and then talk about how we really listen to people and how we can center patient experiences in our work and in the development of materials for diabetes care. So before we start, I just want to say, discussions about bias can be challenging. We all have some level of bias that we bring to the table based on our experiences. And so this session is not intended to make anyone feel badly about that or feel ashamed. This is something that we are all coming to the table with in all different ways and combinations. And, we have all addressed in different ways. And the idea here in having this discussion is really to open up for all of us the potential and the opportunity to make shifts in our practices, however it is that we engage with patients, to really center that patient experience, to truly hear what's happening with folks, and to have a partnership with our patients as we move through working with them and their diabetes care and their own journey. So, I just want to start by saying that before we dive into talking a little bit about implicit bias. So, implicit bias, what this is unconscious bias. So these are associations or assumptions that are occurring outside of our conscious awareness. And of course, this can impact us in many ways. Everyone has some implicit bias that they bring to the table. And I do want to acknowledge a large part of this comes from growing up in systems, that have systematically marginalized and excluded some groups. And so having grown up in that environment, all of us take some of that on to some degree. I also want to acknowledge the role of explicit bias, which is, bias that people have and they're aware of, and they, may have become aware of it, or this is something purposeful. We don't see that as frequently in healthcare, but it's certainly a possibility. And then I also want to acknowledge the place of kind of well-intentioned assumptions. And this is something that can impact the care that we provide and how we relate to people as well. And we'll talk a little bit about cultural humility versus cultural competence, but all of us also have things we have learned through the course of our lives, through our work, that we may believe is helping a situation, and actually we're stereotyping a group or making an assumption that's incorrect without truly hearing what someone's experience has been. And that may be done in very good faith, with the intention to not make someone uncomfortable or the intention to honor what someone's experience may be, but it can happen that it's misplaced. So these things don't happen in a silo. There's implicit bias, there's explicit bias, there are these intentions that people have or things they've learned in the past that may actually not continue to serve them or their patients. And those are all kind of happening together. So I want to acknowledge that as well. So in terms of implicit bias, again, this is what is kind of happening in the background. These are assumptions that are made. It influences the decisions that we make for patients that we're working with, what we might offer to them. And so these are kind of happening outside of our consciousness. In terms of healthcare workers, studies have found that healthcare workers have about the same amount of implicit bias as the general population. It is true that healthcare workers have a much higher standard for themselves in terms of fairness, in terms of providing equitable care. That's something that we all want. But when we look at implicit bias, it actually is quite similar to the general population. In terms of how this might impact clinical care, so some studies that have been done with healthcare workers have shown that for healthcare workers with a higher level of implicit bias, they are having poor patient communications, poor patient interactions, and it is impacting what is offered in terms of testing, in terms of interventions. And so there is an impact on clinical care of implicit bias. Something else that I'll mention about it that I think can be challenging as a healthcare provider, because there's not much we can necessarily do about this phenomenon, but there is something we can do in terms of our awareness. Studies with healthcare workers have also shown that the more stressed someone is, the more cognitive load someone is experiencing, and kind of the more rushed or under pressure in terms of time someone is, the more likely implicit bias is likely to manifest. So, all of us working in a clinical setting know you can't really control how busy your day is or how stressful it is, but just having that awareness and being able to kind of take a pause and step back and say, like, wow, I'm under a lot of pressure. This is a time to really think about what's being offered to people, about equity, about kind of how you're moving through your day. And it's just something to be aware of. So in terms of how this might impact patient-centered materials and how we center patients, I think it might be helpful to just quickly think a little bit about a couple common examples of implicit bias and how it manifests. I think that helps kind of give some context, and then we can think about diabetes in particular. So two of the very kind of commonly known manifestations of implicit bias in our healthcare system in the United States, one of them is that female identifying patients are much more likely to have physical complaints attributed to mental health concerns. A woman comes in and says they're having difficulty breathing, and it's more likely to be attributed to anxiety than it would be for a man. Another example, which is widespread, is that in seeking emergency care, Black adults and children are less likely to be offered adequate pain management if they're coming in complaining of pain when compared to white patients. So those are two examples of how implicit bias can manifest. In terms of the development of patient resources around diabetes, we might see this in the topics that are chosen, in the areas that we think people might be interested in, or the areas that people, for example, don't have access to. So if we're working with a group of folks who are experiencing homelessness, a provider might not choose to develop a cookbook, for example, thinking that people are not going to have access to cooking facilities. Another way would be who might be chosen to contribute to the development of those materials. So that could happen, with all good intentions, but there can be some implicit bias that plays into that. And then also in terms of our approaches on how we frame issues. So we could be missing opportunities to talk about challenges people have experienced, barriers, or things that have worked if we're kind of excluding some folks inadvertently from the conversation. Next slide, please. So that brings us to talk about cultural humility. And the idea of cultural humility, this is a way that we can address implicit bias. It can feel somewhat discouraging to know this could be something happening in the background. You don't even necessarily have an awareness of it, and kind of how do we address this? How do we bring some awareness to how we're navigating with patients and, the decisions that we're making around care and the development of resources? So cultural humility is a way to do this. Having some ongoing self-awareness and having an openness to being kind of a lifelong learner, and really having a curiosity about our patients and their personal experiences and identities and what they are going through, what their goals are. All of this opens us up to move away from what might be an automatic response to really hearing someone and being able to be a partner with them and incorporate what they're saying into kind of how we proceed. So I think it's sometimes helpful to think about cultural humility in contrast with a previous term that was more commonly used before, which is cultural competence. So cultural competence implies that we can gain a complete competency about a group of people just by going through a learning session. I now understand about XYZ group, and so I'm able to work with them. And it also implies an endpoint. And cultural humility can be contrasted with that in that this is an ongoing process. It's a lifelong process. In cultural humility, there's a focus on self-awareness, on a critical assessment of one's own biases, what we are each bringing to the table, and kind of how that might impact how we interact with others. There's a curiosity about learning about other people's identities, and also an acknowledgement of how complex people's identities can be. All of us bring all different experiences to the table. We cannot be defined by just one aspect of our identity. Cultural humility also recognizes and challenges power imbalances. So this is very important for us and how we are thinking about diabetes. There is an inherent power differential between any healthcare center staff and a patient. And so we're trying to break down that power differential and have a true partnership with someone. And again, it really centers the patient as an expert in their own life. So that is cultural humility, and that is the way that we can address some of what's going on with implicit bias as we're moving through, meeting with patients and going through this ongoing learning experience ourselves, and also developing patient-centered resources that are truly going to be of use to people and be meaningful to them. So I do want to talk a little bit before I turn it over to Dee Dee and to Art to share their own expertise in this area about listening to patients and the provider as an expert versus the patient as an expert, and how we can kind of work in these realms. So in these interactions, the provider has some expertise, whatever kind of provider you are. If you're a community health worker, if you're a peer, if you're a nurse, if you're a prescribing provider, if you're a registered dietitian, whatever your role is, you have an expertise in that area. And so this is not meant to diminish that expertise that you have. You have a lot of knowledge, and you certainly have things to share with people. What we really want to do is lift up the experience of the patient. And so let them know that they are also an expert. They're an expert in their own life. They're an expert in their own body and their health and their own experiences. And historically in healthcare interactions, we have really diminished that role for patients. And it has been the healthcare staff saying, this is what's happening. This is what you need to do, kind of the end of story. And what we want is to lift up those voices and experiences that people have had, to learn from them, and so that that person can feel that they're in control of their own health. For the folks that we are working with who are historically, have been marginalized, have experienced discrimination, have experienced inequities, have really been challenged in the healthcare system, a lot of times the folks may feel disempowered around their health and their body to begin with. And so that's something to think about and acknowledge as we're talking about interacting with people. And also with diabetes in particular, diabetes can really feel like a loss of control. And I'll let other folks speak on that more if that's something they want to add to, but it's a significant diagnosis. People can feel really blindsided by it. They don't necessarily feel they're in control of it. They don't know what they're going to do or how they're going to manage it. It can be quite frightening. And so for us, it's really important as healthcare providers, in whatever way we're working with folks, to really listen and hear what people are experiencing, what their own goals are, what their fears are. And that allows us to learn so much about, what will be helpful to that person and to our patients in general. So I do want to acknowledge a couple things. A provider and patient might not always agree necessarily on the course of action. And I think we have all experienced that. As a nurse, there are certain things that I think someone should do if they have a very high blood sugar, or if they're continuing to have high blood sugars. but that doesn't necessarily mean it's in alignment with the goals of the patient. And so a big piece of what we need to do is learn how to ask questions to truly hear what's going on for folks and find a way to work in partnership around something that is meaningful to the patient. So a way I often think about this is, like, for me as a nurse, a hemoglobin A1C is meaningful and important. And if someone's hemoglobin A1C is 10, that's concerning to me. And for some people, that's also concerning, but for other patients, that just isn't as meaningful. That number is not as meaningful, but what they're experiencing is meaningful. And so maybe they're, having frequent urination, they're waking up all the time at night, they're having to pee, they're having vision changes, it's causing them to not be able to see what bus is coming, and they don't know what bus they're going to get on. They may be having frequent yeast infections or skin rashes. And so by asking someone open-ended questions, you really can learn a lot about what's going on and figure out how you can come together in a partnership. And so it might not be exactly in the way the provider had envisioned, but it's so much more meaningful and impactful if it's in the way that the patient has envisioned and is meaningful to them. So some of the questions we might ask people have to do with, how do you feel about your diabetes diagnosis? What does diabetes mean to you? How is diabetes affecting you? And then, as we're meeting with people and finding out how it's going for them, really starting to dig deep with folks about what is happening, not just repeating the same thing again to say, oh, your sugars have not changed. You really need to take your metformin. Finding out from that person, what is going on? Are you taking it? What are the things you're eating? What do what kind of food resources do you have access to? All those questions that could allow us to learn a lot more about someone. And so that process is kind of the fertile ground for what we could then develop in terms of patient resources, and really learning from people and finding out additionally if folks are interested in helping develop materials, which I know we're going to talk a little bit more about in a bit. It really allows us to learn about things that we never would have considered. And I can say, as a nurse, I worked as a nurse for 15 years, and there have been so many things that I have learned from people that I never would have had any awareness of previously if I hadn't been able to listen to them. And, for me personally, it has been an ongoing learning process too, of, recognizing times that an interaction didn't go as well as I had hoped and trying to figure out why, or, if I'm not connecting with someone, trying to talk to them further and find out what is going on and how can we work on a goal that is their goal, that's going to help them feel more in control of their health care. And, even if that's not the goal of the provider, starting to take those little steps really builds a trusting relationship where people can continue to take bigger and bigger steps towards what they want to do with their health and their diabetes. Mm-hmm. So we may find people that, this is just a few examples, which I'll close with, about things that I have learned through working with folks. I've had people who are uncomfortable taking medications. You may come across folks who they have had a life experience around medications for them or a family member that was really frightening or concerning. And so they're really hesitant to take medication. And so they want to use a different route. But if we, don't ask people, we will not find out what's going on. Some folks that I've worked with have not taken the prescribed meds, but have instead decided to use ingestion of vinegar as a treatment for diabetes. And so how can we kind of learn about that and work with that person around, it sounds like they want to do something that is not medication based, and see if a lifestyle change could be effective. I've had other folks who have been diabetic for so long, they have a perceived hypoglycemia, so they feel like their blood sugars are very low when they start to drop below like 250 because they've been high for so long. And so that's a person where we would try to figure out how can we work around that feeling to try to kind of slowly bring that sugar down so they're not feeling these perceived crashes because their body's been living at this high blood sugar level for a long time. People have fears around needles. Some people may not believe they're even sick or have diabetes, but they're having some symptoms that they do want to address. And so that's an entry point to try to work with them and help. Another big issue that I didn't know about is at first was people selling their test strips. So for folks who have limited resources, a lot of people sell their diabetic testing strips. And that is challenging in terms of diabetes management because then they aren't able to check their sugar. And so by being able to have an open dialogue with a patient and finding out this is something that's going on, there's a potential to make a plan. Maybe some of the strips can be reserved. Maybe we can order extra, that you test 3 times a day and you can test once. You have to kind of do these workarounds for folks when you know that things are happening in the spirit of working with what someone's reality is. So those are just some examples of things we might learn. But I think the ability to learn things from our patients is unlimited. And by really having a partnership and listening to someone and what their experience is and letting them set the pace and the goals, we have a much better chance of moving forward than we would if we just kind of gave directives to people and, they don't listen to us and then nothing happens, so we really want to work with people. And so with that, I'm going to turn it over to, I don't know, Darlene, if you want to jump back in, or I'll turn it over to Dee Dee and to Art, and they are going to talk.
Art is going, and I apologize, but for some reason, I'm having such a hard time moving my slides. That's why, there we go. That's why I was for the last one. There it is. So Art is going to share his personal experience, and then after Art shares, then Dee Dee's going to come on and share her experience. But there are some questions that some individuals indicated last week. And so we tried to incorporate some of your questions into what they're going to talk about. But Art is now going to share his personal experience and kind of go over some of these questions here on the slide. Art, I will have you join us now.
Hey, welcome. Good morning, everyone, or good afternoon for some. So my name is Art Rios Sr. I live here in Portland, Oregon. My HCH is Central City Concern. I have been going to Old Town Clinic for quite a while. I was diagnosed with diabetes about 15, 16 years ago. And I was homeless at the time. I worked real close with my PCP, and we went through and made sure that I had the right medications. Some medications worked for me, some medications didn't. I did the whole vinegar thing. I had I just heard from Kate about high A1C. When I was first tested, I was at a 10.7. Then I was sat down in a classroom and learn what was needed and what was wanted for my body to change that impact of all that sugar and things that was happening with my body. I just was taking medication and doing everything I could. I was being tested every 3 to 4 months on my A1C. I watched it little by little go down, not too much, but it took me a while. And then for about 3 to 5 years, I was able to manage it. Then just recently, about 2.5 years ago, I finally lost that battle, and I now have to take insulin. I only take insulin once a day. I stick to my medications. My A1C still fluctuates between a 6 and a 9. I can tell when my body changes on me from when I have a high sugar to a low sugar. I get a little bit of shakes. And it was once again going back to my PCP, talking to them about what is needed, what is wanted for me, and what would be healthier for me. I just recently did my A1C once again, and it came out to that I have a 6.2, which is something that I have never seen in the last 15, 16 years since I've been diagnosed. And so my doctor says that's really, really good for me. She says, keep up the good work and keep taking your medication, keep doing what you're doing. but also throughout that whole time, the resources that was provided to me was how to eat right, making sure I'm checking in, making sure I'm checking my numbers, watching, the carbs that I was eating, to proteins that I was eating, to vegetables, like which was good, which was not good. Just a lot of different combinations. A lot of resources that was very helpful, that I could go to some other organizations and, like here today, talking to people about, you should get your diabetes checked. It's not a scary thing. It's just something that can really hurt your body in the long run. And so I have been able to talk about this and be very helpful as another resource of someone who's gone through this, but gone through it while I was homeless. And my clinic at the time would actually hold my medication. So that was the nice thing about it. I could go to the clinic every morning and get my medication from them. So I didn't have to have my medication while I was on the streets. That was one of the biggest resources and supports that I had for my clinic at the time. I've been in housing now for the last 6 years. It's been a great opportunity for my clinic still to be there to help me with this. But my only thing that happened was, when what did not help was that I ended up with a different PCP that said that we were going to do insulin. I was given the insulin supplies, the pin needles, the alcohol wipes, and that was part of my new regimen, of taking insulin once a day. And so I took it home. I'm looking at everything, and I didn't have the education on it. I wasn't told how to administer or how to set my pin up or where I was supposed to take my shot. So as a consumer to my clinic, I'm also on their Health Service Advisory Council. I brought it as a suggested that has to be an educational piece for people who have to start taking insulin, because it's very viable that they do it right and they're not doing it wrong. And so it's like a step-by-step, and my clinic got on it real quick. And they started having trainings for people who had to become insulin based users. And the engagements that impressed me the most was that it didn't happen like a month down the way. It didn't happen like 2 months down the way. It was like, no, next week, we're going to do this. We're going to contact all of our folks that are diabetic, that uses insulin, and we want to make sure everybody is trained right. They found out a big percentage of folks weren't taking their insulin because they did not know how to use their insulin or how to administer their insulin to them. So it was something that I brought up on an educational piece that helped our clinic in a big way. Now we keep these numbers of folks who are diabetic at A1C, persons of color, to economic status, to everything, that we all get everything equally. No one gets something better than the other. We're all equal. We're a diverse group of folks that get to sit around a table and talk about our diabetes, what educations that we have learned from our clinic, and also what are other services that we may need from our clinic to keep going through if some of us don't want to take certain medications or need extra medications. So it's been very helpful through my clinic, and they're still there for me and still support me. But since COVID-19 has hit, we've seen that that is one of the populations that our doctors or our medical assistants will call out to us and make sure that we're coming in and doing our appointments. And that's been the nice thing about it, that they give us these reminders that, hey, it's been a couple months since we've seen you. Have you been taking your numbers? You need to get your A1C done. I really like that concept since COVID has started, that they're still checking in with us, making sure that we're making it back to the clinic to keep us updated and whatever else we need in our healthcare. Thank you very much, everyone.
Thank you, Art, so much for sharing your experience. And Art, we're going to have a Q&A after Dee Dee presents. And so now Dee Dee, I'm going to turn it over to you. And of course, I was fooling around with my slide while Art was talking to see if it would move. And now it won't move. Dee Dee, go ahead and start your presentation, and I'll try to figure out how to get my slide to advance. There you go. Dee Dee? Dee Dee? There you go.
Okay, can y'all hear me?
Yes, ma'am.
Hello?
Hello,
Okay, great. Anyway, okay, great. Once again, I'm Deidre Blanchard, known in the community as Dee Dee. I would like to be very authentic with you all and share my experience as a diabetic from the beginning. In 2009, I was rushed to Kennestone Hospital, and I found out I was diabetic type 2. What had happened was earlier in that morning, I actually drank a gallon of milk, and my girlfriend came over and she said, "Oh no, we have to go to the hospital." And we did. And all the doctors and the nurses and the team, they came around and, took all these tests and stuff. And that day I found out I was diabetic. But what really happened was I had already knew about diabetes since a young girl, because my mom had my younger sister at the age of 35. And the doctor told her later on in life she would get diabetes because my little sister weighed 10 pounds, 8 ounces. And sure enough, in my mom's late 50s, she became a diabetic. So I watched her struggle with it, just getting common knowledge and reading up on things. But really, really, when it hit me in 2009, I did not know which way to go. I felt so lost. I thank Mercy Care to this day because they took me under their umbrella and they started treating me and talking to me. And what really helped me was those classes. When they say a level of ignorance is no excuse, I stayed in denial for about 2 years. It was 2010 when I walked into Grady Memorial Hospital and said, I want to sign up for the diabetes class. And that was a challenge for me because I had different people telling me different things. I'm talking about providers. So as I became very active in volunteering and helping out, I found my A1C level to be 14. It stayed 14 for years. As a matter of fact, in 2015, it went down to 10. I had an A1C level of 10. And it really threw me off because I had stopped eating all the starches. I even canvassed for the shelters to give diabetics, healthy food and get them off all that starch, because all you get is, pasta. I canvassed to change the menu at the different churches, and I felt like I was giving back to the community by speaking up. So as of today, I still have a high A1C. I mean, I might go down to 8. I watch everything that I eat. It's like I'm walking on shelves. I lost 54 pounds. And I thought that would have made a difference. But my doctor said, I spent all my life, eating wrong, eating starches and all that. And it wasn't going to change overnight. So today I still have a real broad challenge. And I say broad because I can look at something and my sugar will go up. So what I do is I actually maintain a healthy diet by eating a lot of green veggies and everything. But what didn't help me at all was when I would go to the dietitian and have a class or something like that. I mean, they would give me all these nice things to eat, but I have to let y'all know, and me telling you and being authentic, I couldn't afford all that stuff. So I would listen to the names of the foods and stuff like that. And then there was one lady at the farmer's market. She took me under her umbrella and she started teaching me things I can eat that were healthier than what I was eating. And so as I got, on through the years, I learned how to embrace my diabetes. Being a diabetic, it makes you feel like a life sentence has been put on you. But like I know, and for whoever else knows the higher power, no, there's no challenge we can't conquer. So in all my doings, I just started participating and stopped rebelling against everything. Everything the doctor would tell me, I said, oh, he don't know what he's talking about. And I kept my bad habits. Being from New Orleans, I was raised on triple starches. I'm talking about white rice, potatoes, and bread. It took years for me to break that cycle and turn to green. And that's what I do now. I eat a lot of green veggies and stuff. But what really would help the clients is that you follow up with them like I'd be saying 14 days. When they do 90 days, do you know the damage I've done to myself in 3 months? And I know it's about manpower, how many clients you have to serve, but more has to more has to be given, to a diabetic, because if you give them a plan to follow and they're willing to come out of the situation that they're in, they're going to follow that plan. And then as far as A1C levels, look like every 30 days, that would be great. I went 90 days without getting my A1C level. And in everything that I did after rebelling so much, I actually started participating with the providers, asking them questions, finding out things that I can do. And just like Nurse Kate said, that's a strong point you made, because when we go through things, instead of trying to fix it, we get depressed when you're dealing with mental health, like a chronic depressive person, and then they got diabetes. You get to a point where you don't even want to think about it. You throw it to the side and start doing what you normally do. But one thing I must say, it is all about behavior. That mentality of doing a lifestyle change to get them 54 pounds off of me, I feel like I'm just soaring to the top because I'm participating with my providers. And that's very important. And if you want to know what really makes a patient want to open up and talk to you, it's when you show concern. You don't just sit there and write on the chart and, I'm going to increase your insulin by 5, or I'm going to increase. You actually talk to them, and that makes them talk to you and become more proactive in their getting their health in order. Because what really meant a lot to me was when all the nurses and the doctors, they used to call me sugar baby. I said that 2 years ago. I went to Emory as a special patient, and they were saying, oh, here comes sugar baby. I used to laugh and think that was cute, but when I realized how serious my glucose level was off, it made me get serious and say, hold up, I stopped eating this. I don't eat that. And I started participating in my regimen. And I did see changes. And I have to report, y'all, in January the 6th, the 7th, and the 8th, I was in the hospital because I didn't even know I had a mild stroke. My sugar had went up that high. Now, mind you, I had misbehaved November, December, and January. During the holidays, I had, my family, my sister came to visit, and we, kind of remedied all our little recipes from New Orleans, but they still didn't help. It took effect January 6th. I was in Grady Hospital, and the doctor told me, he said, "Look, you done had a mild stroke." I didn't even know. I remember getting dizzy one time at my working station, but I leaned on my table and I pulled myself together. Do you know, and y'all, I'm attempting to say the word, cerebellum in the back of my brain. He said it was damaged a little, but it's going to heal. I am so grateful that it didn't take me out, because I know people that done had diabetic strokes. And all I want to say is, in ending, is providers, thank you so much. Nurses, doctors, thank you for caring. It means so much. Even when we get in our stubborn ways, we still need you guys, and we need your support. And I thank you. And today I am on 2 types of insulin, Humalog and Livermere, and that was only because of what happened the 1st of January. But I'm getting better. My walk is better, and I want y'all to know I'm still out for the challenge, and anything y'all need to know, you feel free to contact me, because I have a resource level that is unmeasurable. I do not want for anything. I'm thankful for all the grants that allow me to get my pens, through the government. And so I am doing better, and I will continue to strive. And I appreciate you guys taking your time to entertain diabetes. Thank you so much.
Thank you so much, Dee Dee. Appreciate you and Art, your time, and just thank you so much. I'm going to.
You're so welcome.
Yeah, thank you. I'm going to now, I was trying to share with the group 2 of the resources that we developed with the National Consumer Advisory Board. Now it's going. 2 of the resources we developed through the National Consumer Advisory Board, both the Dee Dee as well as Art helped us with this. The first one is the things to do during the COVID crisis if you have diabetes. These 2 resources came about when our Consumer Advisory Board asked us, can we do a fact sheet to really help educate individuals experiencing homelessness, first one on diabetes. And so what we did is we drafted the council staff drafted it, but then we sent it out to Dee Dee, Art, and several other persons of the working group to ask for their intake and their input and their feedback. And so the topic came from the National Consumer Advisory Board, the patients, as well as the feedback on both of these. And the second one is the virtual visit. This is just kind of telling people, as health centers started transitioning to telehealth, many patients, clients did not know how to engage in the virtual visit. It was very new to them, and they had not received in-depth instruction. And so we were asked to develop just a fact sheet as far as what type of equipment do you need and that type of thing. So I just wanted to share with you how you can develop resources with input. The idea can come from patients, and they are also willing to give feedback as needed. So I just want to ask Dee Dee, and I'll bring you, Kate, back in this conversation as well, and Art. So what strategies, this is some of the questions that came from the last session. How do you identify patients to provide expertise and resources? And how do you keep patients engaged? And then the final question was, how do you help patients to remember to bring their blood sugar logs? Does anyone, the 3 of you, want to address, and I'm looking at our time to make sure that we can address these quickly and then move to any other question that someone may have. Anyone want to address any of these 3 questions that are presented here?
Yes, I would like, when you say engage, I would like to state that once, like I said earlier, when you're dealing with your client, your patient, whatever, listen, it's very important that you make the session be about them. Show concern, like to make them want to participate with their health. See, some people just show up for their doctor's appointment just to get the prescription, hear what you have to say, but to actually become active, they must know what's going on, not only with their bodies, but with the, I'm going to use the word remedies, what you're trying to put together as a factor to make them get better. When they see that you're concerned with them, you know, it makes us become proactive. You know, and we want to help and we want to get better. But when we just are dictated to, oh, do this, do that, that doesn't make a person think about, well, why is this really going on with me? And you know, you want to bring it to them where, like, they have a say in it also. It's not just you pointing out, this, you do this, you do that. You need to tell them why. You know, say, you get them involved by letting them see, like me. I don't take all them technical terms to heart. I be telling you I'm trying to be authentic with you, and I'm trying to learn the terminology. When I dealt with A1C and everybody kept saying it was 14, I didn't know the average could be 6.5 or 7. They just kept saying, oh, your A1C level is high. Oh, I mean, I went like 2-3 years with the, and finally I have a Christian sister that's a pharmacist. And I said, well, they keep telling me my A1C level is high, it's 14. She said, oh, girl, no. You know, I didn't get active right away knowing what an A1C level is. But when someone took the time and explained it to me and showed me a chart, say, you here, you need to go here, I got interested. I got very interested. So in getting the clients to engage themselves, that is the utmost important remedy to go through to treat your clients. You got to make them be proactive. That's very important. Thank you.
Thank you, Dee Dee.
I will
Yes.
just have to echo what Dee Dee said. Yeah. If you educate them of what an A1C is, why it is being done, and show them resources, and keeps them active of making sure that they keep it under control, and making sure that you're calling your folks for checkups if you haven't heard for a while. And you know, sometimes we forget to go back in and keep checking ourselves. But it's really nice when you actually have staff that call you and say, hey, you know, it's been a while, because we become so busy, or people have had to quarantine, and, you know, it's the COVID-19. That's the other way, that when your staff remember, hey, we need to reach out to these folks as well.
Great, thank you, Art. Kate, was there anything you wanted to add before we move?
Yeah, I was just going to quickly add, you know, I want to, Art and Dee Dee, I think you guys captured so much of this and how to keep people engaged, and it really does make a difference. And I think, Art, you mentioned a support group or a diabetes education group, and I think that is it's obviously been challenging with COVID, but that is such a great way to identify people, and even a group who might want to provide some feedback or expertise. And the other thing I'll say is, you know, I don't think we just want patients who have done great, although that's very helpful. You know, there may be patients who have really struggled, but who want to, you know, people want to give back to their community. They want to help other people in general. And so even for someone who's struggled, that might be a person to tap to say, like, hey, you've really had a hard time with this. I know you worked really hard on, you know, your diet or in get exercising more, whatever the person has kind of struggled with, and that perspective can be so valuable too for other people who are in that same place, having those same struggles. And so it's not necessarily just to highlight the folks who have done really well or have been successful. It's also looking at and talking to people who have had a more challenging time. And then I'll just add one final thing, which is to jump off something that Art said about people not knowing how to use their insulin, just to highlight once more how much of a difference it makes the way that you kind of draw people out and talk to them about what's going on. And so I think all of us have probably had the experience of going to the doctor or nurse, the provider, whoever it is, and they kind of will say really quickly, are you doing good with this? And it's very hard to say like, no, I'm not. It's hard to answer that question. Someone says, are you taking your insulin? And people feel ashamed that they're having a hard time, or they don't know that they're struggling or doing it wrong. And so they just say, yep. And just changing that wording a little bit to say, tell me about what you're doing with your insulin. That opens up the possibility that someone can truly tell you and show you what's going on. And so I think, just like Dee Dee said, really talking to people and having those open engagements makes all the difference in the world. And I think would motivate people to stay more active in their care.
Great, thank you so much, Kate. Thank you, Art. Thank you, Dee Dee. Just wanted to point out at the
You're
bottom
welcome.
to other resources that our consumer patients have developed. So please follow, visit that link. And then also, I'm going to skip the Q&A because we're running out of time. But if you have a question, you can place it in the chat, or you can always email us for that. And then also the council is having a consumer leadership summit, and Dee Dee as well as Art are helping us plan this, as well as our National Consumer Advisory Board. So just wanted to bring this to your attention. And then I will turn it over to Alexis to talk about the next upcoming sessions.
I think it's actually Lauren who will be,
Lauren, okay.
Or Sabrina who will be presenting.
Okay, thank you.
Hi, everyone. Thank you for joining us. And this is just a reminder that our next session will be next week, February 3rd, the same time, 2 p.m. Eastern time. And session 4 will be the week after, February 10th, also at 2 p.m. Eastern time. And the link is here on the bottom in case, so that you can go to our Google sites where you can access all of the resources and recordings and our contact information. Next slide, please. Yeah, thank you again. The evaluation poll should have popped up on your screen, so please complete our quick session poll if you can, just to evaluate how today's session went for you. And thank you for coming.
And
Thank you.
And thank you to Dee Dee and Art and Kate for joining us today. Thank you so much. It was great to have you as part of today's session.
Anytime y'all need me, I'm here, okay?
Thank you. And these are our
Thank you.
contact. If you have a question that we didn't get to, if you have something that you would like to reach out and ask, please feel free to do so. We will definitely respond to you and answer any questions you may have. And with that, I think we are closing out. So everyone have the rest of a good day. Take care.
Okay.
And we'll see you next
Okay.
week.
Thank you all.
Bye-bye.
Bye-bye.
Bye-bye. Thank you.
Thanks,
Bye.
President.